you got to focus on where you're going and keep moving forward and not get distracted. There may be distractions to the left of the path, there may be distractions to the right of the path, there may be noises, there may be problems, there may be things going on, but you really need to keep your eyes on the horizon and where you're going and that finish line. So just to sort of wrap up my metaphor, I want to acknowledge some of the best long-distance runners that I know on this issue are on our panel today, and are hosting this event, our friends at New America Foundation, longtime grantees of our foundation. So I want to, with those words, and hopefully we're all kind of in our running mode and have our running shoes ready to go, I want to turn it over to Micah to go ahead and kick off the event.
Great. Thank you so much, Virginia. I'm Micah Weinberg. I'm a Senior Research Fellow in the Health Policy Program at the New America Foundation. I live in Sacramento, which has not been the most upbeat place to be recently, so it's good to be down here in San Francisco. And I'm going to be your moderator for today. A few housekeeping notes. Please turn off your cell phones unless you have a really exciting ringtone that will help liven up the proceedings. Food and drink are not allowed in the auditorium, so we're going to adjourn to lunch in the Latina room across the hall before the end of the time. For those who need to leave early, some of you might, we will be opening the room just before 1 so that you can grab your box lunches on the way out. So here was my plan for today. The speakers on this panel, as Virginia Witt said, are some of the best people on this issue, some of the best long-distance runners. They're also very influential people. They're also my favorite people. So when you put together something like this, you got to figure out who you're going to bring together, and we really brought together a great group of people here. And what we're going to do is we're going to try to get a little bit below the talking points. You know, I work for a policy research institution, so we're really going to try to dig into this a little bit more than the folks maybe on the left or the right have. This isn't really a place where we necessarily want to rehash the heated political arguments that are going on, but really shed some light on what are the choices that face us, what are the decisions that we're going to have to make, and how are we going to move forward on this issue. I have a few questions for the panel, and then we'll open it up to all of you. So who are these folks? Wow. To my left is K Schultz. He is the presidentially appointed director for Region 9 of the U.S. Department of Health and Human Services, which includes California, a few other western states, and the Pacific. There are states out there, territories out there. He tells me all about them. Nations. You know, one of the difficult parts of his job is having to travel around the Pacific. Formerly, he was senior advisor to Governor Schwarzenegger and director of the California Recovery Task Force. He also served as acting secretary for Labor and Workforce Development under Governor Gray Davis, and has held many key positions in the private and nonprofit sectors, including vice president of government programs for McKesson Health Solutions. He's also a good friend. To her left is Betsy Imholz. She is Special Projects Director for Consumers Union, the nonprofit publisher of Consumer Reports, which I'm sure you have all heard about. And both she and her organization are powerful voices for consumers, both in the States and in Washington, D.C. Previously, she was the Consumer Law Coordinator of Legal Services for New York City and the Director of Consumer and Employment Law Unit of South Brooklyn Legal Services. To her left is Paul Markovich. Paul is Executive Vice President and Chief Operating Officer of Blue Shield of California. Sometimes there's a little confusion because in a lot of states, Blue Cross and Blue Shield are the same company. Here in California, as many of you know, that's not the case. Blue Shield is a 3.5 million member not-for-profit health plan. And Paul has served in many positions at Blue Shield over the course of the past 15 years. He is also an entrepreneur, a Rhodes Scholar, and an excellent hockey player. Our last speaker was to be Cindy Enos, who's the director of the Department of Managed Health Care in California. She's unfortunately detained in Phoenix, but is sent as her last-minute pitch hitter, another one of my favorite folks from the healthcare world, Rick Martin, who is the Deputy Director for Plan and Provider Relations at the Department of Managed Healthcare. So another thing you need to know about California is that we have a Department of Managed Healthcare. We're hearing a lot about health reform and health insurance in the race for the insurance commissioner, and certainly the insurance commissioner will have an important role in health reform implementation. But in California, it's actually the Department of Managed Healthcare, which doesn't report to the insurance commissioner, but reports to the governor, that is the largest regulator of health insurance, and in fact, the largest regulator of health insurance in the entire nation. They have about 20 million enrollees in the products that they regulate, whereas the Department of Insurance is about 2 million, so about 1/10 the number of actual plans being regulated. He's been an important part of this debate, and I'm looking forward to hearing from him and the rest of the panel. So we're going to kick things off talking about what's going on right now. We're probably going to talk a little bit about 2014 here at this event, but 2014 is a long way off. And there are a lot of concerns, whether it's related to individuals, such as some of ourselves buying health insurance, whether it's related to the state safety net, that we really need to talk about what's going on today. So that's what we're going to start out talking about. And to start out that conversation, I'm going to turn to Herb.
Thank you, Micah. Thank you, Leaf, as well. All the support from the New America Foundation and your strong partnership in implementing a successful healthcare reform, as well, Virginia, to the Blue Shield Foundation and all the partnership and work that we're doing together. I've worked with everybody on this panel, and like Micah, I can call them all friends. I'm glad that Micah did not mention my musical theater career, which is on hold because of this position. And I will not sing today, so that's probably a good thing.
Go ahead.
Not without a piano, and do not wheel one in. I want to also acknowledge my colleague Eric Alborg, who is the first ever in the region Director of Outreach, Policy, and Communications for Region 9. And I also want to point out Mark Herbert, a colleague who is District Representative for Speaker Nancy Pelosi. And I do want to underscore one of the best things about moving to San Francisco is to be able to call not only Nancy Pelosi my Congresswoman, but Speaker as well. And she and Mark and his colleagues have been enormously supportive as I've come in to work in this very large region. I have, in a little way, I have sort of an easier part first, and then we think all the questions and answers, it'll change. But Micah asked me to sort of provide an overview before we get into the exchange. Excuse me one second. My colleague David Sion, who is the regional administrator for CMS, as well as here, so I wanted to point out David. But I'm just going to provide you at first sort of an overview in sort of two ways. One, the sort of first 6 months, if you will, the progress to date, and then some of the things that happened last week in terms of the 6-month anniversary and all of the new consumer protections that go into effect. So when President Obama came into office, he pledged to put America back on the right track. And together, we've begun to create a more competitive, consumer-friendly healthcare marketplace to crack down on the worst insurance company abuses and to provide real benefits to people in need. That's already happening today, thanks in part to the Affordable Care Act, which, as Virginia and everybody have mentioned, passed just 6 months ago. We didn't tear up our current healthcare insurance system and start over. But what we did is set out instead to build on what we have, to keep what works, and to fix what's broken. So the Obama administration has been working to deliver health reform benefits to the American people. And in the last 6 months, let me tell you what the administration has been doing. We've ensured that people who have been denied coverage because of a pre-existing condition can enter a high-risk pool program to get the insurance they need. Made fighting fraud, waste, and abuse a top priority, and we're helping consumers by providing states with critical new resources to crack down on unjustified rate hikes. Seniors are being provided new benefits that will make Medicare stronger and more secure than it has in years. And as we know, hundreds of thousands of seniors in California have fallen into the so-called prescription donut hole. And nationally, we've already sent out $1,250,000 checks, rebate checks, to eligible seniors and people with disabilities. Thousands of employers and unions across the nation have been approved to support early retirees who are not yet eligible and to help the former employer and the former employee be able to better afford health care. And almost 500,000 small businesses, and this is where we emphasize small business, meaning not only for-profit small businesses, non-profit small employers. Almost 500,000 in California will be eligible for the new tax credits and credits, if you're nonprofit, to help provide coverage to workers and make those premiums more affordable. So perhaps most importantly, this past Tuesday marked the date when critical new consumer protections came into being, what we call the Patient's Bill of Rights. And so if you think back for a second, and I'll say, close your eyes for 5 minutes, 5 seconds. I'll make it 5 seconds. But if you close your eyes for 5 seconds, you think about where were you before March 23rd, 2010? And then we stop today and think about, wow, we're at September 27th, last Thursday was September 23rd. And on September 23rd, many of us who have advocated our whole lives to see this happen, comprehensive reform, woke up to knowing the following. Insurers can no longer deny children coverage because of a pre-existing condition like diabetes and asthma. Individuals will receive preventive care with no out-of-pocket costs for services like mammograms, colonoscopies, prenatal and new baby care, HIV screenings, and I can tell you as a person living with HIV for almost 20 years, it's monumental to think about that being as affected as so many millions of people are with chronic healthcare conditions. Insurance companies can no longer drop your coverage when you get sick simply because of a minor mistake in an application. And there can no longer be a lifetime limit amount spent covered under your plan on medically necessary services. And I think another important one is that insurance companies will no longer be able to charge consumers more money to go to emergency rooms that are out of network. So if you happen to be in an area and you go into that emergency room, same charge. So these reforms are protecting many consumers today, but the law says on and after September 23rd. So they will protect many more people, millions of people, as they renew coverage or enroll in new plans. And it certainly does mark a turning point for the insurance industry. So as these reforms take effect, they're also a bridge until 2014. And I'm glad we're actually going to talk, hopefully, beyond it as well as before it. Because 2014 is the date. So that's when, in 2014, still more important benefits of the new law begin. New health insurance exchanges where families and small businesses can purchase coverage regardless of health status. And the largest middle-class tax cut for health care in American history to help them afford it. Lower-income people will get help to afford premiums on a sliding scale, and members of Congress will get the same coverage as everyone else. So the groundwork is already being laid here and across the country. And since the passage of healthcare reform of the Affordable Care Act, the Department of Health and Human Services and our administration has worked with Congress, has worked with governors, has worked with federal, state, local, tribal, territorial officials, healthcare providers, patient advocates, academics, philanthropic organizations, and others to implement this new law. We've rolled out powerful new resources like healthcare.gov and cuidadodesalud.gov, where for the first time you can visit a single website that will lay out all your health insurance options. And in October, all of those options will come with average pricing information. The law is not perfect, but it does a lot of good, helps a lot of people, and we are working to improve it. So today and in the months ahead, our focus is on implementing these solutions effectively and getting them to the people who need them. Get those benefits to the people who need them. It would have been easy to put these reforms off, as we've done in the past. Easier in part because of the recession. We could have said, well, we know our healthcare system isn't working, but we'll fix those problems later. But we believe that fixing these problems is absolutely essential to putting our country back on the right path, and that has really been our focus over the last year and a half. And as we go forward, that focus will not waver. So thank you, and I look forward to a very active discussion. I will say I have cards here. They have my cell phone and my email. Folks that know me know that I give it out, and so I hope that many of you will be talking directly with us at the department. Thank you.
Thanks, Herb. Herb went through that big list of all the people that the federal government is working with and partnering with, and actually he's met with half of those people. And if you know Herb, or if you get to know Herb, he's constantly meeting with people over half the globe, and he's tireless. So thank you for that overview. Let's dig in. Let's dig into some of these a little bit. Let's talk about how this is actually going to work in our lives going forward. So to start off with that process and get into some of the details, Betsy, do you want to?
Sure.
Thank you.
Micah posed a difficult question to me. He was trying to prepare us a little bit for this, although it's a pretty informal agenda. And he said, I'd like you to talk about the most important provision in the new law. And I said, what are you talking about? First of all, the law is, as we all know, lengthy and filled. It is not one silver bullet solution. It is filled with just an array of really wonderful new provisions for consumers and to improve the healthcare system overall, including containing clause, which is a big concern, I think, for all of us for sustainability of this wonderful new program. I just would point out that we have, Consumers Union has a booklet out front. I think it's on the table out in front, Micah?
Yeah.
And if there's none left, just ask me, give me your card, and I'll get you some. Or you can go to the Consumer Reports website. It's a free downloadable brochure about the benefits that took effect September 23rd. And with pictures of actual people who contacted us with their stories and how these new rules are affecting them to their benefit. But when pressed, I said, all right, I'll choose two things that I'll talk about. And so I guess if I were a parent with a child with a chronic illness, I would certainly say that the guaranteed issue for children up to age 19 is probably the most important thing I can imagine. We've had heart-wrenching stories, and actually if you go on the Consumer Reports website, the free part, there's a thing called Ask Nancy, and our senior health writer, Nancy Metcalf, is taking stories from people about their experiences, and some of the most heart-wrenching ones are about families who have children with pre-existing conditions who, for one reason or another, the family hasn't been able to get coverage. Either their employer health plan didn't provide it for dependents, or the parents themselves didn't have it through an employer, and they had a pre-existing condition. They couldn't get a family policy, etc. So I think that that new provision to ensure that children are able to get coverage without regard to medical conditions is absolutely critically important. And the estimates are that there's more than 500,000 kids in California alone who could be denied on the basis of having a pre-existing condition. Now, we have all heard in the news, we don't want to ignore the fact that there has been news recently about some plans dropping their child-only policies. Different problem. I know HHS is in dialogue with those companies and trying to put out some guidance to suggest some ways to alleviate some of those concerns that those insurers had, but it's a wonderful new provision. One other thing I want to point out is that there's a bill on the governor's desk right now. We, in fact, have about a dozen bills sitting on the governor's desk now. One of them is Assembly Bill 2244, which would apply to plans offered after January 1st, 2011. And this would set up the structure for guaranteed issue for children in California. So it implements the federal law, but goes a little further. It does it earlier, and it puts a cap on the amount that insurers can charge for children with pre-existing conditions, no more than twice that for a healthy child, and then phases that out until 2014 when there should be no difference in cost. So that's the one. One I would emphasize is the guaranteed issue for kids. The other one I want to bring up, because it doesn't always rise to the top, although Herb did mention it, is about the preventive care provision. Very important, obviously, for personal health and for population health, long-term system health. and cost containment down the road. We're not going to see the prevention benefits, obviously, right away in terms of systemic costs, but overall we know that's where we have to go. It's one of the places we have to go in order to contain health system costs. So as Herb said, it requires no copays, no deductibles, no coinsurance to get these important preventive services, and applies to everyone except for the grandfathered individual plans. There's a little nasty grandfather, which we may get into later. I don't know if we want to.
Well, no, go ahead and explain that. The grandfather issue is a big issue in healthcare reform. This gets back to the if you like what you have, you can keep it issue that we talked about. So.
Right, and so if you had a plan on March 23rd, 2010, and there's no significant changes to that plan by the insurer, then that's considered a grandfathered plan, and many of these new benefits don't apply to that. So preventive services is one. So if you've got a grandfathered plan, you may not see the benefit of the prevention, just sort of free preventive services right away. So, I mean, those are the main two I just wanted to touch on. I know others have other provisions to talk about. The preventive services stuff is proven prevention measures. That is, those on the U.S. Preventive Services Task Force guidelines, rated sort of an A and B, which means simply that they're really proven preventive services that have been shown to really improve health or prevent illness. So in the long run, I think covering these services, as I say, should help not just our individual health, but hopefully help us sustain costs, which is going to be so important to make sure that these wonderful new reforms are sustainable in the long term.
Great. Thank you so much. Paul?
Thanks, Micah. I really thought Virginia's analogy about a marathon was apt. It also made me a little nervous. I'm not much of a runner, and if I go out for a 5-mile run, I'll hit the proverbial wall about 1.5 miles. So it makes me a little worried about what this means if I apply the analogy to health reform. But that aside, we, as Micah mentioned, we're a not-for-profit. We're headquartered in San Francisco, and we have been advocating for nearly a decade for universal coverage, which requires comprehensive reform. So we are excited about the fact that September 23rd is here, and we're actually implementing it and making it real, which we've been doing for months. It's not easy. There's a whole lot of work. There's a whole lot of complexity, and it certainly won't be smooth even from here on out. But it is an exciting day. It's an exciting day for us. It's consistent with the mission that we have to ensure that all Californians have access to quality health care at a reasonable price. It's something we think needs to be a minimum, and this goes a long ways towards that end. To the question about, well, what specifically, and there's a whole lot of things in this bill, as I'm sure you all know, what specifically maybe stands out as potentially making a difference. I think the dependent age up to 26 is a very useful provision. That the estimates nationally are that anywhere from about 680,000 to a little over 2 million young adults in this category are going to get access to insurance, and probably half of them will have been uninsured. And so getting those folks covered on their parents' policy and making sure that's the case, especially in this recession, because we know the younger population is having a harder time finding jobs in this economy, I think is just a terrific benefit. So I won't take up any more airtime. Happy to answer questions or dive in more deeply on others, but that's the one that stands out to me.
Great, thanks, Paul. Rick?
Well, all the provisions are important that come to light on the 24th. Some will be more important to others than others will. But some of the big ones that the department feels really hits home is that insurers can't cancel coverage anymore. I wouldn't be doing justice if I didn't promote the department and its efforts to get rid of rescission in California. I mean, a couple of years ago, we went from over 1,500 cases to just this year less than a handful. So really, I think this provision throughout the nation is really bringing the rest of the country up to what California's achieved. Consumers will get direct access to physicians and care. You will be the one that chooses where to go, what doctor to see, what OBGYN to see, not the health plan. There'll be no more additional payments for emergency care when you go to a hospital that's not in the plan system. And annual limits on coverage will be going away, and most importantly, there will be no lifetime limits on coverage.
Yeah, great, thanks, Rick. Okay, so this all sounds very exciting. All these great new protections. But you know, every once in a while I turn on the television. There is some concern expressed as to whether or not it will be possible to roll some of these protections back based on the results of the election, or now in 2014, we're definitely going to talk about how to get there. That's a long time away. So, do folks need to be concerned that these provisions might get rolled back? Is there any sort of truth to that larger political story?
I hope not. I mean, I think it's very difficult, for us to make political prognostications about elections and what's going to happen next. But I certainly hope that's not the case, and I don't think that it will be. I'm sure there'll be a continued debate on this, but I certainly hope and don't think that it'll get actually repealed.
Yeah, we'll have a chance to hear more from the audience on these issues. I think the important thing to emphasize is that it would require, given that the president is committed to health reform, it would require a Republican victory so large that they would be able to override the president's veto. And that's not going to happen. There's 0% chance of that happening. There are some, funding strategies around the margins. But I think that the more important point to make is one that gets totally missed in the political debate. And that is that it is not true that there is a group of people out there for whom healthcare is totally set in stone. They don't want to make any changes at any point now or in the future. Health reform is it. And then there's another group that wants to see it all torn down. That's just not true. The Republicans support a lot of things that are in the healthcare reform bill, and the Democrats acknowledge that many changes need to be made. Now, the changes that they make may not be the same changes, but there's actually a tremendous amount of agreement, even on some changes that need to be made related to, for example, some reporting requirements around small businesses. And there's a lot of agreement on things such as insurers not being able to deny people for pre-existing conditions, which is the beating heart at the center of healthcare reform. So certainly political dynamics are going to be important, but we're not, I'm not, as of yet, a talking head on any of these commercials and or on these news programs. And so I think it's really important to emphasize that everybody acknowledges that this is a process, even if we have different ideas about where it should go.
If I may add something, I just think it's worth remembering, sort of taking a historical perspective, that for many of these major pieces of social legislation that have been passed, they haven't necessarily been uniformly popular at first. And so we know there's going to be a lot of pushback, and we just have to, I think, all of us do our best, and we know those officials that we have at the table here are doing their best to make these reforms work as best they can, and hopefully then the public will start to see the benefit and some of that opposition will die down.
Yeah, we'll see. We will see. But one of the things that the public is concerned about is the following, and here's another place I want to dig into this. So a lot of people thought, like people have asked me, Micah, when's healthcare reform going to kick in? I'm like, well, what do you mean? And they said, well, my premiums are still going up. When are they going to start going down? And I don't have the answer they want to hear. And so I want to dig a little bit into this issue of, since people are still seeing their premiums rise this year, maybe less than they would have, but certainly in line with what they had been in recent years, what, if anything, is in the healthcare reform bill that addresses that now and in the next few years? And what can we do about the premiums and out-of-pocket costs for people?
Well, I would just say, we could be here for quite a while if we listed all of the benefits that are in the law and are already in the process of already being in effect for many people. We talked a moment ago, when I made comments, that 46 states have received $1 million each to strengthen their systems, if you will, without getting too technical, to ensure that healthcare prices, healthcare rates are, increases are justified. That is one thing. Those are $1 million. That's a lot to states, and that's a lot of activity that's sort of going on there. Number two, you look at things in the preventive health realm that we're talking about. So on and after September 23rd, you talk about zero co-payments and zero deductibles and zero co-insurance for a heck of a lot of very, very important preventive benefits that are, quite significant and will ultimately be able to assist in terms of premium costs. You talk about the small business tax credits that we talked about. They are in effect now, and that is for-profit companies. They can get up to 35% off the premiums they're paying. For not-for-profits, up to 25%. In 2014, that amount goes to up to 50%. And so there are changes. The early retiree reinsurance program, without, again, getting technical, that is right now over 2,000 companies, unions, cities, states, counties have been given and are being given help in order to be able to better insure the retiree premiums, to be able to stop what many of them have to do is scale it back. So I'm sure my colleagues will want to kick in, but there are a huge set of provisions in there. Health insurance technology that now is having electronic medical records happen. All of those things, if you will, and many others, are already working in the system to make coverage more affordable. And so it's not a 2014 thing. It is I do a PowerPoint presentation that says 2010, 2011, 2012, 2013, and 2014. And there's a heck of a lot of slides on 2010 and 2011. I'll mention one other. In Medicare, starting January 1, in addition to zero co-payments, zero deductibles on preventive services, you've got two really big things going on. One is that every person on Medicare, seniors, people with disabilities, will have the benefit of an annual wellness visit with their physician and the development of a personalized prevention plan, again for zero copay, zero deductible. The other thing is that on January 1, in order to close the donut hole, that prescription drug gap before 2019, 50% off most brand name drugs, if you will. So these are monumental reforms that are in place, going in place, and will shift, if you will, some of the cost from the consumer and from the small business that's seeing them now.
Okay, fair enough. I mean, the rest of the panel, did we do enough? Could we be doing more? How can we actually bring these premiums and costs down for folks?
There's a lot of stuff, even beyond what Herb mentioned, that goes to the underlying drivers of healthcare cost in the bill, including a new center on comparative effectiveness research, that term that's thrown around. What does that mean? Looking at what is, among drugs and procedures and devices, what's the most effective method of taking care of a medical problem. We all know that there is a problem with unnecessary care, sometimes over-intervention that can actually create more harm. So there are safety issues that arise in the system that actually end up costing us billions and billions of dollars. Consumers Unions had a big campaign on stopping hospital infections, for example. Those billions of dollars and lost lives as well that I think we're starting to address with some of the measures in the healthcare reform. And in addition, we have a new emphasis on rate review. California, frankly, is not, amongst all the states that we've looked at, California is not great on insurance rate review. But we do have a bill on the governor's desk that would take us a little further on that, would improve things a little bit. That's 1163, SB 1163, which would slightly improve the rate review. It's not all we wanted, but it would, the main benefit I think of it is that it would give us more information about some of the underlying drivers of cost in the insurance system. And so that combined with money from the federal government to beef up our rate review and our actuarial folks who can actually look behind the numbers that, you know, us average folks can't really do so well. They can really look at the numbers and comb through. As we saw in California, that was pretty effective during the reform debates when one of the insurers did make a big proposal to have a big jump in rates.
Yeah, Paul, I want to come back to you, but since we're talking about rate review, Rick, do you want to jump in on that? Because you're, one of the guys who will be at the center of trying to figure that out.
Got him right here.
Yeah. So you guys just work it out between each other, okay? We'll just get these rates reviewed right now.
Yeah, I can tell you what I hear about the rising costs, but that won't be fair. But you mentioned
Or maybe legal.
California, per se, being poor in the rate review. One of the reasons why is that the Department of Managed Healthcare has never really had any authority over rate review and approving or denying. But if the governor signs 1163, I think that we'll be in a good position to answer that question in about 12 to 18 months in terms of what are the real cost drivers that increase the premiums year after year. I think that giving us that ability will help with reform come 2014, come today, 2014, and well beyond that. We are one of the recipients of the $1 million grant. We're splitting it 60-40, 60% for DMHC because we applied for the grant, and DOI gets 40% of it. But hopefully we can take that money and turn it into something good that we can really answer these questions of why rates are really going up instead of all the hearsay that's going on.
Mike, what I wanted to mention is that when it comes to cost, in getting people covered is a huge part of trying to, and a big step in trying to address the underlying cost issue. If you look at the fact that there's now 50 million people nationwide in the latest census information that are uninsured, one of the dynamics we face all the time as commercial health plans is that the hospitals and physicians are treating people and either not getting reimbursed at all or getting reimbursed entirely below what they normally expect. And to make up for those losses, they come back and negotiate higher rates with the one entity or the entities they can, which are the commercial health plans. So by virtue of, if there's no other bigger statement that this is unsustainable than the fact that 50 million people are saying, I can't afford this, I'm not going to pay for it. That is not a sustainable system. And if we're going to end up, I tell our staff all the time, we're going to end up insuring a couple of families in Beverly Hills and Palo Alto if this keeps going this way, because they're going to be the only people that can afford a health insurance policy. We need to bring people into a pool, and that's why I think reform is important and does take a major step towards addressing cost. With that said, that isn't going to be nearly enough. We all need to relentlessly focus on this. But the other thing I said to my colleagues is, well, what the heck is our job? If you're looking for the government to solve this problem, then what are we doing? It's, I think, our job, and when I say ours, I mean the health plans, the hospitals, the physicians, the entire delivery system. I think it is our responsibility to be looking for new and different ways that we can bring to the table to help address the cost issue. It's complicated. We could spend weeks on it if we chose to up here, but it's things like, we have a big pilot now with Catholic Healthcare West and Hill Physicians for 40,000 members in CalPERS, where we've completely changed the way we pay, we've completely changed the way we work together to try and improve the quality of care, and we delivered a 0% cost of healthcare increase for 40,000 members in 2010 over 2009. And we're tracking to that within like a point so far year to date. It's pretty radical compared to the way we've done it before, but that's the sort of thing that I think ought to be coming from the private sector, and certainly we expect to be doing a lot more of to try and help address this problem.
And let me pick up one thing that I think Paul just said. Prior to March 23rd and as of July 1st, we have what's called the Pre-Existing Condition Insurance Program. Well, what does that mean? That means individuals, adults, individuals, and small businesses. But let's talk about the individual in the individual pool, and I'll get to small businesses and the exchanges in a second. But that program, and California will be operating that program very shortly, I believe, moving forward to 2014, is what we sort of call, the temporary pool for people who have been medically uninsurable. There will be a cost-effective, good package of benefits provided to tens of thousands of people who have been denied the cost of health insurance, who have been denied health insurance, or may, frankly, have had health insurance and due to the cost, went through a personal bankruptcy or just wasn't able to afford it and dropped coverage. That is a huge monumental shift that across this country there is now a way for millions of adults who have used hospital emergency rooms and have used community clinics that then can't get compensated for the care, lots of different things. But if we think about the high-risk pools, that's another huge driver in terms of that national program, and it was up before July 1st, which was in the law. And then I think the couple others that I just wanted to mention really quickly. The health insurance exchanges or the marketplaces where individuals and small employers will be able to get health care. Those are not, if you will, up at this point, but there are drivers that are working towards those. Two other really quick things. Anyone ever hear of what never events are? Never events are when you go in the hospital or an ambulatory surgery center and they're supposed to take off the left arm and they take off the right arm. And in today's world, the government has paid for that. In other words, paid twice to go back and fix, we left the sponge in, all of those sorts of things.
Put the arm back on.
Thank you.
Yeah.
Okay. This reform ensures that we're not, as a government, going to be doing that again. And there are huge patient safety initiatives that are in there. The other one is the hospital readmissions. Most of the hospital readmissions that we say are in the first 30 days. And so there is a real focus on ensuring that everything's done the right way so that there aren't hospital readmissions in the first 30 days. And the hospitals will get penalized to a certain level if they have a pattern of doing that. So those are things I just wanted to mention because there are things happening today and a huge number of people getting in and getting insurance for the first time and getting access to preventive care before they get sick is huge.
Great, thank you so much. So I could ask questions all day, but I'm not going to. And in fact, Lori, could I put you on the spot? Because I know you want to ask the question that was going to be my next question. So if you want to kick us off. Unfortunately, there's not a mic, but I think we'll be able to hear you. And if we can't, I will... Oh, there is a mic. Oh, terrific. Okay, well then, Amin will bring the mic down to you. And then after Lori, we'll open it up to the rest of the audience. She's over here on the aisle.
Thank you. Good afternoon. It's a pleasure to be here. My name is Lori Baptista. I'm with Traverso Vasquez Health Center over in the East Bay and also with the California Primary Care Association. The panel will be dismayed to know that I have 2 pages of questions and heartened to know that I've narrowed them down to only 2. My first question, Ms. Imholz referred quite often to prevention measures. Mr. Markovich, you spoke briefly about quality, affordable health care. Mr. Schultz referred very briefly to the work of community health care centers, and all of you talked about keeping costs down. Community health care centers have been doing all of this, have been health reform since their inception during the 1960s with President Johnson's War on Poverty. And Mr. Markovich, you spoke to quality, affordable health care. I think one issue for those of us living in California is the issue of diversity and the fact that community health care centers not only provide quality health care, but they provide linguistically and culturally competent health care. How often do we have patients or family members that either are not, English is not their first language? That alone will be a significant improvement in providing care to an increased Medicaid population going into 2014. My question is regarding the unique system that California is facing right now with the state budget, as Mr. Weinberg referred to, more or less falling off a cliff, and the continued cuts to the healthcare safety net. While we're looking at what's happening in 2010 right now, community health centers are having to prepare for the expansion of patients all along and through 2014, in addition to the additional people we're seeing now because of the people losing their jobs. So, my concern is that while we're preparing for 2014, the shredding of the safety net continues, and there is a concern there of what foundation is going to be left when all of these new people come into the healthcare system.
Yeah.
And if I could go one other thing for Ms. Imholz, one of the issues as well was we talked about preventive, keeping costs down. And to that end, I'm wondering if someone could speak a little bit, please, to the, 85% requirement for health insurance companies that goes back to patient care, and if that will make an impact both on costs and effectiveness.
Okay, two small issues. What's going on with the state budget, and are we taking one step forward, two steps back here? And then the other small issue would be what they call the medical loss ratio. But let's talk about the budget first, because that's good times.
Well, I think my employer exempts me from talking about the budget.
No, hold on.
Can I say that about my employer?
Help a brother out here, guys. Come on.
No, I mean, I think we have to talk about, it's again, I said at the beginning, making political prognostications is, I think, difficult for this group to do, apparently impossible for some, but depending on the topic. But I think in our positions for our organizations, what can we do to help be a part of the solution if there's a challenge, for example, with community clinics? And I'll try not to make this paid advertisement, but we have established a foundation that we put $30 to $40 million a year into, that they in turn put into the community, and it focused largely on helping the underinsured and uninsured. And many of those dollars, over $100 million has gone into the community over the last 3 years, go to these community clinics. I also go to preventing domestic violence and other things. That is not going to be nearly enough to address the issue that you mentioned, but I do think it's an example of, when we're each in our different roles, are we trying to do something to be a part of the solution? And I certainly think that we are. And I think if we had a chance to vote on the budget, then we might be in a better position to predict how that's going to work out, but I don't think any of us do.
I've long made the statement when I worked for the state, and I also have started to make it now. You cannot divorce or look at just health reform as health reform or the budget as the budget. You cannot separate the fact that we have a state budget, that the state and the federal government are negotiating what we call an 1115 Medi-Cal waiver to bring additional federal funding into California, and for healthcare reform. So if we talk about healthcare reform for a second, the community clinics will be the recipients of $11 billion over the next 5 years. $1.5 billion for construction, and most of the rest of that money for increased services. As a matter of fact, we have an RFP out right now for up to $250 million to put in effect 350 new sites. It could be an existing federally qualified health center, or it can be a new one who will get grants up to about $650,000. We could talk about things like primary care, and there are significant incentives in Medicare and in the commercial side for better reimbursement for providers to bring access, and many of those folks will be accessed in the clinics. So I think that when the state talks about the waiver process, they talk about it as a bridge, a delivery system bridge to going to 2014. And as I said before, you just cannot separate that out. We understand what state budgets are like, absolutely. And everybody works on that day to day. Everybody's also working on the waiver, and also everybody's working on the implementation of that. So I could go through a number of examples, but I think suffice it to say, you cannot separate out those issues. Understanding the difficulty that at one point you're talking about the potential for a program not being funded, but then bringing in extra money and then being required to provide additional folks coverage.
And then, are you going to explain the medical loss ratio?
Yeah.
Or?
The medical loss ratio is basically how much and we've got a system in place. Let me tell you what the law does. That the law basically says that if you're an insurer and you are providing health care to either large employers or you're providing them to small employers and individuals, that you are limited on the administrative and profit that you can make. So either 80 cents on the dollar or 85 cents on the dollar must be spent on medical care and the remaining on administration and profit. And that's a process that the department with the National Association of Insurance Commissioners, consumers, business, health plans, folks are vested in what the definitions will be. But there will be a standard so that insurers across the country will know what they can do. And in 2011, what the law says is report that. Let the sunshine in. Let us see, let consumers see, let businesses see what is there. But in 2012, if you say you're at 18% instead of 15%, consumers will get rebates based on the amount that the plans went over. So it really is a very important, not only cost, reducing containment measure, it is a quality measure to make sure that consumers are getting the best bang for their buck in healthcare.
Okay. If we could turn to some other questions. We have a lady in the back, Amin, right there by you. If I could, just because I want to get to we have a decent amount of time left, but I really want to get to more of your questions. If out of respect for your fellow members of the audience, you could ask one question and keep it under 30 seconds and make it a question, I would greatly appreciate it.
Or you have my cell phone, as everyone will get, so we can talk later.
Or just call her later.
Please identify yourself.
Good afternoon. My name is Mary Jessup. I'm a philosopher and writer, and a concerned and interested participant today. Thank you for your wonderful work, all of you on the panel. I want to ask a question or just plant a seed for our country to think about, and that is creating a one sentence or one phrase statement in present time about the health of our people, as in Americans are healthy, or something really simple that includes everyone, visitors, immigrants, all of the native born of every color, shape, and size, so that we all have something to live into, to live with, to aim for, to focus on as our health commitment to ourselves, our families, our future generations. And out of that, this is the other little seed, that we look at our long-term risks that we don't have a clue about regarding genetically modified food.
Yeah, no, thank you.
And so I want to ask if any of you are thinking about genetically modified food, because we don't know what's going to happen long-term in the next generations, because all of it's going to be passed through the DNA. I can promise you that.
Yeah, I mean, I think that it is an issue for some, from some folks. Betsy, did you want to address that a little bit?
I was just going to say, Consumers Union does work on these issues and has a precautionary approach to these things. So you might take a look at our website, consumersunion.org. We're doing a lot of food safety work.
Great, thank you. Ma'am, down in the middle of the front here with the blue shirt on.
Hi, I'm Usha Ranji with the Kaiser Family Foundation, and I wanted to follow up on the previous discussion about the safety net, and just specifically this very large Medicaid expansion that's coming down the road, and what, I guess, I'm bringing as a question, sort of what activities over the next few years we should be preparing for, specifically on the issue of Medicaid provider reimbursement, and really shoring up the delivery system to meet the needs of this expansion, both and sort of what the state is doing on that front, and I guess what you would suggest advocates should be doing as well to strengthen reimbursement.
Yeah, I just think that's so critical. You can't give people access if there's nothing for them to access, or if there are concerns about provider capacity or hospital capacity or so on. So.
Yeah, I mean, at the federal level in the law, and there's a lot of things going into place. On October 1, so a couple days from now, primary care physicians in Medicare will see a 10% increase in their reimbursement. Starting on October 1, general surgeons and health professional shortage areas in Medicare will see a 10% jump in reimbursement. That is for each of the next 5 years. When we get closer to the Medicaid expansion, the first 3 years that is paid for by the federal government 100%, in 2013 and 2014, primary care physicians, nurse practitioners will be paid, the Medi-Cal rate will be equal to the Medicare rate. And that is a calculation that will happen. So that is a large increase for the Medi-Cal providers who will now be seeing a greatly expanded Medicaid program. Because you asked about workforce, or you mentioned workforce and all that, I mean, there are millions of dollars. We have a public health and prevention fund, as you know. This year it's $500 million. There are huge dollars going into workforce development, workforce training, all of the sorts of things, provider and workforce diversity, let's put it that way. So there are a lot of things that are happening in terms of the access side, including the reimbursement issue.
Great, thanks. The gentleman in the third row here on the left.
There's an important question not being dealt with here, and that's history. That's the important question in the room. 90 years ago, this country took an identical leap into the future with a great new idea that was going to change the world. It was going to start here. It was going to improve everything. And it was called the prohibition of alcohol. It was a terrible disaster because the people who did it had the best of intentions and had not done the due diligence. We now know this. Now, the great lesson of history is that mankind learns nothing from history. And I'm sad to stand here and take my whole 30 seconds to tell you, until we deal with the problems, not of intentions, not of illness, not about poor people who are left out in the cold in front of the emergency room and have no help, who die out under the bushes somewhere. Look, I'm ex-public health service. I've been involved in this sort of thing for a long period of time. There is an enormous rethinking needed. If we do not do it, this effort will fail on an economic basis. I'll give you one quick reason why from history, and it's this. When prohibition of alcohol came in, it shut off approximately 20% of federal revenue, period. The alcohol taxes were about 20% of federal revenue. That shrank the government, and when 1929 came around, bad things happened. Look, this is complicated, and what I am saying is, I hear the triumph in everyone's voice. I welcome what you're doing, but due diligence has not been done. We have enormous problems ahead, and 2,000 pages of intentions are not solutions. Thank you.
Yeah, I think, and I want to move on because that's more of a comment than a question, but we had about, agree or disagree with what happened in the healthcare reform, we did 100 years of due diligence on this. And maybe the intentions aren't going to work out, and Lord knows, there's not triumph in our voices. If you're recognizing anything in my voice, it's maybe a little bit of fear, because I don't think there's anybody up here who would tell you that they are 100% confident that every decision that we made was the right one.
And Micah, just one comment is, I think if we end up prohibiting the consumption of alcohol, it will make implementing this bill much more difficult. I can tell you it's
I think we're not, well, there are other issues related to ending prohibitions in California that we're not going to get into here, but
That's not in your boxed lunch.
Yeah, no, nothing fancy. John, up here in the front.
Thanks very much. John Graham from the Pacific Research Institute for Public Policy. Earlier this week in Boston, Harvard Pilgrim announced they're pulling out of the Medicare Advantage market because of Obamacare's Medicare cutbacks. 22,000 people in Massachusetts will lose their Medicare Advantage benefits. Would any of the panelists like to predict which carriers will drop out of Medicare Advantage in California, and how many seniors will lose their Medicare Advantage benefits?
All right, let's get into this.
You know, I do. I mean, I don't know how you predict that, especially if you're talking about other, each plan and what they're going to say. I do think that we talked about the complexity of this. There's still a lot to be determined on some of the measures that are coming in terms of how you implement them, how you set up the structure to make it work and be sustainable. I think the example of Kids Guaranteed Issue is a great one. You have to structure some kind of open enrollment process to make the market actually sustainable. There's still opportunities to do this that create fallout, and there may be some, but there's also opportunities, I think, to do it right, and I think if we all focus on trying to get it right, we can limit the fallout in those situations.
Yeah, to a certain extent, the question is, we'll see. The predictions that physicians were going to exit Medicare en masse generally have been made pretty frequently and haven't happened. That doesn't mean they won't happen. So I get it. We need to keep an eye on this, and I know that we are going to keep an eye on it. The gentleman in the back.
Hello, my name is Lee Dime. I'm just a concerned citizen. Hippocrates said, "Let thy food be thy medicine, thy medicine be thy food." As leaders in our community who are interested in prevention, I have one simple question. What did you all have for breakfast?
The question is, what did you have for breakfast? The answer for me is cheesy eggs. It's true.
I had a banana. Does that help?
I had a cup of bran. They just can't.
Yeah. I mean, I
Oatmeal with probably a little more brown sugar than I should have had, and a banana,
I had a cup of coffee on the drive up here because I need to lose 40 pounds.
But the thing is, that might seem like a little bit of a flippant question, but actually I think it's a really important question. I mean, because this is ultimately not about healthcare reform or health insurance. It's about health. And it's about personal responsibility. It's about, everybody living as healthy as they can. And healthcare reform certainly, like you hear that when people get statins to lower cholesterol, they're a little bummed about it. They got this diagnosis from their doctor, they got this new medicine. What is the first thing that they do generally after being prescribed statins? They go out and have a steak. And if our country responds to healthcare reform by essentially, letting its guard down and, letting ourselves, stopping taking care of our own physical health, then it's not going to work. We all have a role in this, regardless of what happens in Washington or happens in Sacramento, and that's basically marginal compared to our own personal responsibility to keep ourselves and our families and our friends healthy.
But ultimately, we will be spending $2 billion a year on the Public Health and Prevention Fund. And it's not just about personal responsibility, and there are incentives for individuals and at work sites for small and medium-sized business, but there are community transformation grants. And this community has been one of the leaders in sort of looking at childhood obesity and things like that. We're working quite actively. The mayor has signed on to Mrs. Obama's Let's Move Cities and Towns, and that is all about letting parents know how to get access to healthier food, providing that access, teaching children and stuff.
Ma'am, in the middle, actually, there in the brown shirt. Well, I'm not sure. Looks brown from here.
Hi, I'm Janet Palma from the San Francisco Public Health Department. I'm going to try not to be too flip here, but I think Mr. Schultz mentioned something about the rate of profit that's going to be allowed. And one of my concerns is behemoths like Sutter Health, who conduct advertising on television every single day, and I have no idea how much cost it takes them to do that. Shutting down hospitals all over the Bay Area because they're not making the profit they think they should be making. And where did we ever get to thinking that hospitals should ever be profit-oriented and profit-driven, where they can do things like that?
It doesn't apply to hospitals. This is a health plan provision.
Right, but I think that the question is an important one, so let's
no, I thought you were specifically saying hospitals. I just want to make clear to the audience that this is for health insurers.
Yeah, because I think a lot of people have focused on health insurers, and Lord knows some health insurers have done some things that require our focus. But there are health insurers, there are hospitals, there are a lot of different people who are involved in the system. And what did the health reform do to address issues like the specific issue that the questioner asked?
Well, the provision on never events is one of them. That those providers, and by the way, Sutter, I believe, is a nonprofit. But anyway, whatever, yeah.
But they're not a licensed health plan.
But they're not a licensed health plan. But the never events and reduced reimbursements for other things like readmissions, those things will apply to those providers to hopefully get them to change.
Yeah, although I guess what I'd say is there's more work to do on this one, is my conclusion, because we know there are dramatic differences within the same community, one hospital that's next to another in terms of cost. And we have, with the quality information that's available, there is no relation that we can tell between how much we spend and the quality measures that are available on these institutions. It's a complete scatter plot when we look at the work. And there can be a hospital that is 3 times more expensive next door to another on a case mix severity adjusted basis. And I think it also plays into the rate regulation is an important part of the health reform bill, and rate review is an important part of the health reform bill. And it's also the case that if you try to do, for example, what they did in Massachusetts and simply say your rate can only be 4%, it's a bit like what we had in the energy situation, right? I'm going to tell PG&E they can only charge so much, but what they pay to buy the energy is unregulated. And so I think we have to be conscious of the fact that you raised. I think there's more work to do on this issue.
And one of the, sorry.
Well, I was just going to say, I think that the issue that you raised is going to have a bigger public profile going forward. I think, that people are really going to begin to get that, because there are honestly a lot of people who thought that the problem was entirely with health insurance. Now there's a lot in the bill that deals with these other parts of the issue, but I think we're going to really be figuring this out. And I wanted to get to a woman in the back in the red shirt.
Yeah, I guess this is...
It's just a sec, we have a microphone coming to you.
Bonnie Preston, I've been involved with promoting the national health insurance and looking at it since 1978. So I too was wishing for more from the health reform effort, but and there are a lot of issues, but we have gotten to a certain place given the current political structure. And what I'm wondering is what I'm feeling let down about from the administration. I understand, I like the idea of focusing on implementation and making sure you're doing a good job, but there also is obviously a public education effort that isn't happening, and that we're losing political ground even for this small amount of ground we've made in health reform. And I guess I'm wondering, in HHS, what is the marketing budget for this health reform because people need to understand. We're losing in the polls. It was always, people are supportive of the provisions of the bill, this is even before it was passed, but they don't like the overall bill because it has a bad market. It was poorly marketed. Now we're in the case where the polls were losing even on those provisions that people thought they liked before. So I'm just saying, it seems that the public needs to see, to hear more from the administration in a marketing way. Good information has to be getting out there and being heard.
Yeah.
You need to put it in more simple terms.
Appreciate the question and the sentiment. Every day, there is more and more and more information that is being given to the public to be educated from HHS, from the administration, from partner organizations that are here. Last week, there were several hundred events across the United States to mark the 6-month anniversary. There are funds in the health reform bill that don't come yet, that are coming in terms of marketing. The secretary, the sub-cabinet, the regional directors, as well as many, thousands of people in the department itself are out doing that. That will not alone be enough. What we're doing, and I think it's working with key external stakeholders, with government officials, and I think that everybody is driving day to day to day to figure out, define more ways to get that information out. There are provisions, I should mention, in health reform because cultural and linguistic competency came up, regarding requiring health plans to be able to work in various underserved communities to ensure that information is imparted and that people can access services. So I understand what you're saying, and we're working every day to provide cogent, accurate, more and more information.
Yeah, it's not by lack of her getting out there, I tell you that. I mean, but ultimately, because I've been following these polls pretty closely, they haven't really moved. They've gone up and down, but as a social science, I mean, the up and downs from month to month are basically noise. The reform bill has the support of anywhere from 45 to 55% of the population, depending on how you ask it. That's been consistent for the last 6 months. It's gone up and down a little bit. Of course, what's come out recently is that the Republicans, are sort of implying that, oh, this is because everybody's upset about the government takeover of healthcare. Well, that's actually not the case. There are a lot of people, potentially, I think, from the way you asked the question, such as yourself, who are concerned that the bill didn't do much, and those people didn't do enough, and those people actually outnumbered the folks who are concerned about government takeover 2 to 1. And so there are a lot of people that are concerned about this, but we're putting together forums like this to get as good information as we can out there about these issues, and I know there are a lot more questions. We don't have a lot more time, so I think what I'm going to do right now is wrap things up and allow you to ask some of the questions to the panelists directly, either by coming up or we have some lunches across the hall. If you want to grab them, I think we'll be able to mill around in the area and keep this conversation going. But I really appreciate, so, this is what I try to do, get good information out there, and I really, really appreciate, these people up here are extraordinarily busy, and I just wanted to thank you for spending your time. If we could get a round of applause for the panel. And Kurt's going to give you his information, but before he does, I just wanted to thank all of you, because you, I'm sure, are just as busy as we are and have other things to do. And I really appreciate your coming out to be a part of this forum. Sorry we didn't get to all your questions, so let's be able to ask some of these more one-on-one, but I just really appreciate it. And thank you so much for coming today.
What I wanted to do is provide my cell phone and my email information. I've got cards here for folks as well to be able to access the department. And in this administration, part of this implementation and part of our, if you will, way of doing things is to ensure that there is a local, regional community presence at the department level. Many of you have dealt with many different parts of the department, but this is the Department of Health and Human Services, and we can help navigate you into places you may want to do or come in your community and do a number of forums there. So it's area code 415-437-8888. 8500 is the direct, if you will, into the office, 415-437-8500. My cell phone is 415-265-7049. That's 415-265-7049. And the email is Herb, H-E-R-B, and it's spelled the East Coast way, I have to say, Schultz, S-C-H-U-L-T-Z. So it's herb.schultz, S-C-H-U-L-T-Z, at hhs.gov. One other quick thing, we have a stakeholder list that is growing by the day. We send out very cogent information several times a week on implementation, on grant opportunities, on provisions that are going into effect, on places to go and specifically look for things, all of those things, and we welcome you to either hand us our cards or to email me and we will put you on that list. And one other quick thing, next Monday, 3 to 4:30 at the Federal Building, we are hosting Todd Clark, who is the Chief Information Officer of HHS. Why is that important? Because he's the person that's in charge of the Community Health Data Initiative, the National Community Health Data Initiative. And Todd will be here, and he and I will do a real discussion. It's not really a presentation, a real discussion with the community. So thank you.
Betsy?
Yeah, just one more thing in the spirit of education too. Again, if you want to give me a card, I'd be happy to try to get you some of our pamphlets to give out. I think it's a great point. We can't say enough about the bill. Healthcare.gov is a great website too. I don't know if you've been on there, but I can't believe how quickly you all got it up and running.
All right, the food is just right across the lobby. We have boxed lunches for everybody. Again, thank you so much for coming, and we're looking forward to the conversation.
Yeah, just push everyone in there.